Good morning, everyone. Good morning, good afternoon, and good evening. This is Johanna Ralston, CEO of the World Obesity Federation. Thank you so much for joining us for today's webinar on management and treatment of obesity in children and youth. We have callers from all over the world, and we're very excited about the great interest in this important webinar today. This webinar reflects work that we are doing funded by the European Union's Third Health Program grant. We're a member of a number of consortia, including STOP and Cochrane. And we will again be speaking to the management and treatment of obesity in children and youth with experts from Europe and Australia. In terms of housekeeping for today's call, I just wanted to mention a few things. We do ask that you mute yourselves while you are on the call. Please submit questions and do them through the chat box, which should appear on your screens. Do send us a note if you're not able to see the chat box. But we will ask that you send questions through the chat box. To the extent possible, we'll answer a question or two between speakers, but we will also reserve time at the end for Q&A from all of the presentations. So again, please do stay muted, and you will be able to submit questions through the chat box. We will also send around a webinar of the recording. So now it's my pleasure to introduce my colleague, Margot Niveau, who is going to be speaking to the management and treatment of obesity in children and youth with a briefing that the World Obesity Federation and our colleagues have developed for European policymakers. Margot?
Hello, everyone. So it's my pleasure to present some of the recommendations we have drafted as part of the policy briefing. So first of all, I'm going to give a little bit of background. So the prevalence of childhood overweight and obesity has been increasing globally. And in Europe alone, it has been predicted that by 2025, 4.8 million children between the age of 5 and 18-year-olds will be living with obesity. So given the wide range of physical and social consequences associated with childhood obesity, we really need to focus on developing treatment and management interventions. So currently, the main goal of treatment interventions is to improve long-term physical health through permanent healthy lifestyle habits. However, the success of an intervention should not only be seen as a reduction in age-adjusted BMI, but we really should see it in a more holistic manner and also consider a person's well-being as well as their emotional status. So currently, Europe remains very focused on the use of multi-component interventions for the treatment of childhood obesity, and the European Medicine Agency still recommends an incremental approach to childhood obesity treatment, of which bariatric surgery should only be considered as the ultimate option. So multidisciplinary lifestyle interventions have been defined as the cornerstone of obesity treatment. However, the most recent Cochrane review has examined the effectiveness of interventions to treat childhood and adolescent overweight and obesity. And while it still favors multi-component behavioral change interventions, it also suggests that they only lead to small reductions in body weight, and that therefore the effects of these interventions is quite limited. So today, clinicians are exploring other combinations of treatment through the development, for example, of novel dietary interventions, as well as pharmacological and surgical treatment options. So we have, based on extensive research that will be available on the dossier that we have just launched online on the World Obesity page, we have drafted a number of considerations and recommendations when approaching treatment options. So we still favor multi-level and multi-component interventions, and we really need to promote a holistic approach that incorporates physical activity, diet, as well as psychological components to really maximize the positive effect of an intervention. We also call for the development of very tailored and targeted interventions to increase the impact of different treatment programs. These treatment programs should really be family-centered and culturally relevant, and we really need to ensure that the surrounding infrastructure facilitates physical activity while at the same time promoting a healthy eating environment. Parents hold a key role in lifestyle interventions given their ability to encourage children to increase levels of physical activity, decrease sedentary behaviors, as well as promote the implementation of a healthy diet. We also recommend the use of key behavioral change components as outlined in the NICE guidelines. So these include stimulus control, self-monitoring, goal setting, rewards for reaching goals, and problem solving. Another issue that came up was equitable access to treatment. So currently there is overwhelming evidence in disparities in obesity prevalence, and the causes of these disparities are likely to be linked either to the success or the failure of pediatric treatment. Following on that, we also call for the use of innovative follow-up techniques. So it is essential for children who live with non-communicable diseases to receive not only appropriate diagnosis, but also regular follow-up to really ensure the tracking and the progression of the disease. We also need to identify the key stakeholders for pediatric obesity treatments. So there are a number of different stakeholders and different levels of government should be involved in both the development and the implementation of these interventions. We also need to consider individual characteristics when establishing pharmacological treatments. So age growth and intellectual maturation are really distinct features between children and adolescents that need to be taken into account when establishing a treatment plan. While we also call for the consideration of bariatric surgery, these should only be considered if lifestyle interventions have been inefficient and considered if adolescents fulfill a set of predefined and very strict criteria, and we really call for a very close follow-up from clinicians. And finally, we also consider the use of more intensive dietary interventions, as some studies have shown that they can lead to modest weight loss among adolescents, while at the same time improving cardiometabolic outcomes. So thank you very much for your attention.
Thank you, Margot. I'm actually going to ask you to respond to one question that came up, if you're able, from Cochrane, which was around, for multi-level and multi-component interventions, do you have some examples of how these can be scaled up to national programs? And have these been successful in terms of having the same level or better efficacy from initial trials? What has been done to find out if the outcomes were successful?
So I am going to refer people to have a look at our case studies that are all available now on the World Obesity page, just for the purpose of time. But we have compiled a number of case studies that all showcase different examples of multi-level and multi-component interventions, and have some suggestions on how to scale some of these programs up to national and potentially international levels as well. And some of these case studies have been showcased in our 10-page briefing. So you can refer to all of this on the World Obesity webpage.
Thank you, Margot. Now it is my pleasure to introduce our next speaker, Dr. Tim Lobstein, who's been head of policy director of policy at the World Obesity Federation. He will be speaking to social disparities in pediatric obesity treatment.
Well, thank you, Johanna. It's a pleasure to join the webinar today. As you can see from the first slide here, it was one of the work packages of the STOP project, STOP being the Science and Technology in Childhood Obesity Policy, funded by the European Commission Horizon 2020 program. We got involved and we got asked to do a systematic review on social disparities in treatment of childhood obesity. So this is one of our deliverables, which I'm very happy to report on today. We took I use the word social disparities to include educational status, household income, ethnicity, and other of the usual sort of socioeconomic measures that we classify populations into. So this was to look at what is the impact, what are the outcomes on childhood obesity for treatment according to different levels or different disparities in socioeconomic status. So we looked at both outcome in terms of BMI or weight classification, but also the process, the access, the attendance to clinical interventions, and the dropout and so on. So we were looking at process and outcomes. We were specifically focusing on pediatric obesity treatment in children with excess weight. So we were not looking at prevention. We looked at studies that were providing interventions through healthcare services or university clinical services. That's to say not in schools or communities, which largely include non-obese as well as obese children. And we were looking at younger children, children aged 3 to 10 years. So that was those were the criteria we were using for our systematic review, and we did a search of the literature. First, we looked to see if there were already systematic reviews that might have covered this topic. We found 634 systematic reviews that included child and obesity in its title or in its abstract, of which 64 appeared to be eligible for good data extraction. They were correct for children's age range, for clinical intervention rather than prevention. They included a 6-month follow-up, that was one of our criteria, and they had measured outcomes, which is another of the criteria. As you will see in a minute when I report on the results of looking at those 64 systematic reviews, we didn't find a great deal. So we then proceeded to look at all the primary studies that those 64 systematic reviews had analyzed, and found that about 81 of them were eligible for primary study data extraction. So that was our source material. And I'll quickly summarize. The slides that you have here will be available to you afterwards, but if I can quickly summarize, of these 64 systematic reviews that were eligible, 34 actually made no reference to social disparity relevant variables, and another 11 reported disparity variables in the methods or the results, but didn't analyze or discuss these. Disappointing. Of the 19 remaining, we did get a few bits of information. Firstly, I should comment that most of these studies were performed in the United States. If dropout or non-compliance was reported, very few studies actually showed how that might be associated with disparities, socioeconomic status, ethnicity, and so on. Where there was some evidence, then Black ethnicity appeared associated with higher intervention dropout, and low family income appeared associated with lower compliance with the intervention, and that there were obviously several variables potentially influencing compliance and dropout, including recruitment method, family self-efficacy and motivation, and willingness of change. So in conclusion on the systematic reviews, there was considerable difficulty getting general conclusions, actually, from about different social subgroups, and several reviews note that interventions often involve better off families with higher levels of functioning, more resources to make changes, and better parenting skills. So there is, in a sense, already a huge bias in the literature towards better off families and certain groups within the social disparities spectrum. So then we looked at primary studies. We found 82. There was 81 I mentioned earlier, but we found another one that had been published after the systematic reviews had been completed. So of 82 studies, we found 5 undertaking some quantitative analysis of treatment outcomes in relation to one or another of social disparity variables. Only 5. 1 found no significant difference in outcome, 2 found better response among children of higher educated parents, 1 found better response amongst children of lower household incomes, and 1 found an interaction. So actually it's extremely difficult to make a conclusion from these studies. So for primary studies, general conclusion, remarkable lack of high quality evidence. Where baseline disparity data does exist and where it's collected, there's often no further analysis. So the most commonly reported ethnicity, when it is reported, is Caucasian or white, followed by African American or Black, and Hispanic or Latino. And of course, these categories do reflect the dominance of studies undertaken in the USA. Well, our findings matched a 2012 review that looked at 61 interventions and found that only 20 of those reported socioeconomic status, and 13 of those studied children only from upper and middle class households, and 31 reported ethnicity, 22 of them Caucasian. So there is this huge bias in the underlying data here. Just to sort of add a few study findings, in reviews and papers that refer to attendance or dropout and follow-up, there are few discussions concerning subgroups, and their conclusions are largely speculative, but the key points arising from them are the ability to attend sessions over extended periods of time will be one of the factors. A lack of rapid results for the child and subsequent loss of interest appeared to be another. And of course, the dynamics of families in different cultural environments and under economically stressful conditions will greatly shape their ability to maintain adherence to treatment programs. Okay, a couple of slides on general conclusions. Well, we already know that there is overwhelming evidence of social disparities in obesity prevalence in children. The causes of these are presumably linked to the success or failure of pediatric treatment. So if there are causes that are socially disparate, then presumably the treatment needs to take great attention to these. But disparities are rarely mentioned in the evidence for effective treatment. So the successful use of pediatric obesity services is likely to be affected by families' attitudes to overweight in children. For example, their culture, their income levels, and their education will affect their attitudes. Families' understanding of the causes of weight gain, families' motivation to make family-level changes, and not just focus on the individual, and above all, the resources that families have available to make and maintain those changes. So we know these as a theory, but the data there is really, really sparse. But it leads us to conclude that interventions do need to be culturally and socially sensitive, to avoid stigma, of course, and to encourage motivation, to recognize the barriers that families and children have, and to try and reinforce the opportunities. That may mean shaping the type of intervention to the person that you're intervening with, that it may change between one person and another. And the failure to understand this can lead to wasted efforts by health workers and lost opportunity for those who are funding the pediatric services. Now, we know there is a high level of policy concern over health inequities and the need for universal access to health services. So tackling inequalities is important, but it does need evidence, and yet this is not being met. So, as a final conclusion, many studies that are paid for with public funds or philanthropic donors, they are collecting the relevant information, but they're not using it, and it's imperative on research funders to make sure that such information is a key focus in future research. Now, we do hope to be publishing the details of this systematic review that we've done in a journal supplement for the STOP project, expected early in 2020. So thank you for your attention.
Thank you very much, Tim. That was excellent and very provocative. I think one question that's come up is, what can sort of people on this webinar, people in this sort of concerned people in this community do to influence research agendas other than what we're doing now in terms of highlighting this in a webinar, and what are some other ways we might be able to call for research to capture these sort of disparities and gaps?
Well, if you are, of course, a researcher already, then I do urge you to pay attention to these factors and to make sure that when you're collecting the data at the beginning, and a lot of studies do, that you actually use that data when you come to analyze the results at the end, and a lot of studies don't. So please, if you're a researcher, don't waste that opportunity. If in any other way that you're able to influence policy, of course, please do, through your professional associations, through your workplace, any other place that you think you can. It is important that particularly public money, taxpayers' money spent on these sorts of interventions, where we know there must be some disparities and some socioeconomic effects, that we don't waste that funded money, and that we do insist that we find out more and use what we've got.
Thank you very much. Now it's my pleasure to go on to our next presentation. Professor Paulina Nowica, who's professor at the Department of Food Studies at Uppsala University in Sweden, will be presenting on lifestyle and behavioral interventions in the treatment of childhood obesity. Thank you, Paulina.
Well, thank you, and it's my pleasure to join. So I was asking myself, what is the state of the art of the field? And some of the key features have already been mentioned. So if we go over to the next slide, in my presentation, I would like to focus on the highest level of evidence, which are the systematic overviews and meta-analysis, and then focusing on randomized controlled trials. So I'm not going to speak so much about observational studies, the cohort studies. I'm going to speak even less about case studies, but I will mention some of expert reports. But I would like to remind everybody listening to this webinar that all studies we find are not equal. So we need to be quite critical about what is the evidence there. So if we go to the next slide, we are happy that the summary of recent summary of Cochrane evidence has been just completed, and it's beautifully summarized in the paper of Louisa Els and her colleagues, and the paper was published in IGO last year. And so this summary is of the evidence of randomized controlled trials from the beginning, from 1968 to 216. So, and most studies were published in the last 2 decades. And the inclusion criteria was that all RCT had to have at least 6 months data from baseline and were aimed to treat excess weight. So in total, 163 studies were found, including about 20,000 participants. 30 countries were represented, and most of them were from, US. 27% were from Europe. Only 10 studies were conducted in upper middle income countries, and the remainder in high income countries. And the individual trial sample sizes range from 10 to 686 participants. And as Tim mentioned before, that socioeconomic status was reported using various methods, and that Cochrane review, that paper concluded, and also the Cochrane reviews, that summary was not possible. That's why the work of the work package presented in the previous podcast was about to kind of see more in detail what was the reason to that. And also ethnicity reporting was limited. And the next slide, I think that the next slide is particularly exciting because it shows with one slide the effect of interventions in different age groups. And the first is the treatment for youngest children between 0 to 5 years. And then the next group is treatment for parent only for younger children as well. And then the next one, the third one, is for children of school age, 6 to 11, and then the adolescent. As you can see, the largest decrease in weight status was found in the youngest children. So this is one of the clues that treatment of childhood obesity is particularly promising for the youngest children, but we have very few studies as well. So if we go to the next slide, if we now go over to the expert reviews and recommendation, these are the recommendations from the Academy of Pediatrics from 2007, and already there they recommend a comprehensive 4-step stage care approach, and as mentioned before, the comprehensive multidisciplinary intervention is encouraged. And if we go to the next slide, I jump over to the next expert recommendation. So 10 years later, this is the recommendation from the US Preventive Service Task Force. And they went over the evidence, and what they found, what I think is interesting, that the intensivity of treatment measures, so more intensive treatment were found to be more effective, and the number that they highlight is at least 26 contact hours. And another finding that is important to highlight, that there were no harms of behavioral interventions, and the harm of screening were minimal as well. And if you go to the next slide, there are a couple of papers that come from the European, from the Childhood Obesity Task Force of the European Association for the Study of Obesity, EASO. And this paper highlights that obesity is a chronic disease. That's why long-term follow-up of treatment is essential. And then if you go over to the next slide, here is another expert technical report from the same Childhood Obesity Task Force, emphasizing the need of careful and comprehensive evaluation at the primary healthcare level, careful assessment of risk factor, and again, multidisciplinary approach. And I would like to finish with perhaps the most important slide, because when I speak about childhood obesity for different audiences, I always get these questions from parents, from physicians, from healthcare providers, sometimes from teenagers. Can obesity treatment lead to eating disorders? And I always say no, and explain, and there are all the studies. But now we have a very recent systematic review with a meta-analysis looking whether treatment of obesity with a dietary component increases risk of eating disorders. So they found 36 studies with over 205,000 participants, and the youngest participants were 7 years old, the oldest 17, and after treatment, they found a reduction of bulimic symptoms, emotional eating, binge eating, and drive for thinness. So the conclusion remains that structured and professionally run obesity treatment was associated with reduced prevalence of eating disorders and reduced risk for eating disorders and symptoms. So thank you. That's what I wanted to highlight.
Thank you very much, Paulina. That was an excellent presentation. We've had a few questions come in, but I think I'm inclined to wait until after our next presentation and then have both you and Louise and possibly Tim address these questions. But this was extremely helpful. I think the one question that did come through that I thought might be interesting to hear your thoughts on is this idea of obesity as a chronic disease, for which there's certainly support and recognition among many professional societies. WHO has indicated support for it and does describe it as a disease in some of its documents. But how do you think sort of recognizing obesity, and particularly childhood obesity as a chronic disease, might change the sort of the experience and the way that the health system addresses the child with obesity?
I think this is a very important question, and I think that we might wait with responding to that question at the end of this webinar, because that becomes particularly relevant for bariatric surgery, when the recent studies, I'm sure that Louise will talk about, have found a necessity of follow-up. So there is no single solutions. We need to have Louise will, I'm sure you will expand on that. So let's keep this in mind to the end of the next presentation.
Thank you. Yes, and I think you've helped. We're introducing our next speaker, Professor Louise Bauer, who is with the University of Sydney, a pediatrician and an expert in pediatric obesity among children and adolescents. So it's my great pleasure to introduce Louise, and she will be presenting on emerging interventions to treat obesity in childhood, especially adolescents. Thank you.
Thank you, Johanna, and Paulina as well. Well, welcome to everybody. Morning, afternoon, and evening to those on the webinar. Go to our next slide. I want to just remind you about the components of treatment of children and young people with obesity, and I've put my slide the other way around from the one that was shown earlier, but essentially I think it's really important that in whatever we do, that there's support for long-term healthy lifestyle change is always there. So whether you're going to have more bariatric surgery or drug therapy or something, you're still going to need to have this support for long-term healthy lifestyle change. I would say that there is both drug therapy and intensive dietary intervention, maybe components that that are adjunctive to this, and that bariatric surgery also is a form of treatment for some people who are more severely affected. And that's what I'm going to focus on now. So on our next slide, I want to talk just briefly about more intensive dietary interventions. I'm aware that these are variably used in different countries, and I think that these are potentially suitable for those with moderate to severe obesity, We do know that in weight, both in adults, but also in children and young people who are having dietary, who are having weight management interventions, that initial weight loss predicts later weight outcomes. And so supporting some more intensive weight loss initially, particularly in those with more severe obesity, may be very useful. We also know there are several systematic reviews now showing that no one dietary prescription is necessarily superior to another. So whether it's a low carbohydrate or a high protein diet, and that probably adherence to a healthful dietary intervention is what is really important. One of the issues we do know is that dietitian involvement is important. And I think this is particularly in children and young people, perhaps less so in adults. I don't know about that as much. I'm aware, for example, that there are dietary interventions in GPs in adults. But I would always say in this age group that you need dietetic involvement because of the importance of ensuring appropriate micronutrient and vitamin intake. Now, the issue about very low energy diets has arisen, and these are often part of the element, one of the most important elements of more intensive dietary interventions. These are typically less than or approximately 800 kilocalories a day or 3,350 kilojoules per day, and they're typically as meal replacements, although they can be with non-carbohydrate vegetables as well, or with very lean meat. A 2019 systematic review of very low energy diets in 5 to 18-year-olds involved a meta-analysis of 20 studies, and these showed a mean weight loss of 10.1 kilograms for interventions lasting between 3 to 20 weeks. And for some of those that followed up longer term, there was a reduction in the actual weight loss, although still maintained out, sometimes out to a year. That study commented that there was limited data on safety profile and hence concluded that conclusions cannot be drawn about safety profile. I will just point out that the concerns about micronutrient, nutritional limitations on products were actually from studies, some decades ago, and that the manufactured meal replacements and so on are now nutritionally replete, and so that those should not be an issue. The issue has arisen about whether psychological harm may come from more intensive dietary interventions. These are not normally actually reported, and so hence the carefulness about conclusions cannot be drawn. This is actually from our group that I work with, so I'm very familiar with these data. Can we go on to the next slide, please? The issue of pharmacotherapy is also really important. My basic summary here is that it's potentially useful, although options are very limited. There are currently few anti-obesity agents that are available in most countries, with few subsidised by government agencies. And you will see that, for example, there are more pharmacotherapy used, for example, in the US than they are in Europe, Australasia, and so on. And this varies from country to country. There have been few trials performed in adolescents, with clinical use often being off-label. In the 2016 Cochrane review on pharmacotherapy, only 2 drugs were actually included, metformin and orlistat. These are 2 currently available ones, and both of them resulted in weight reduction of about 2 kilograms. We do know that there's a greater attrition in adolescent trials than in adult trials. However, we are aware that several ongoing trials are identified, so dealing with topiramate or GLP-1 receptor agonists. And so recommendations as to what medications should be given really vary a bit from country to country. In where I work in Australia, essentially metformin and orlistat are those that are available, and we would rarely use orlistat because it's often the side effects are often unpalatable to young people. But in the US, there seems to be a broader array of medications used, including, for example, phentermine and topiramate. So it does vary from country to country, and I'm just trying to highlight those that are available in systematic reviews. Next slide, please. What about bariatric surgery? I think this is a really important part of potential treatment for young people with severe obesity. Rather than few consensus guidelines, I'd say relatively limited number of consensus guidelines, although they do come from various parts of Europe, North America, Australasia. And they have a large number of common elements so that the patients would have severe obesity. For example, most of them now would say a BMI greater than 40 or a BMI greater than 35 with moderate to severe complications. So, for example, having type 2 diabetes, having moderate to severe obstructive sleep apnea, having moderate to severe non-alcoholic steatohepatitis. Most of these guidelines talk about the young person being in late puberty or near final adult height, and part of this is concerned about future height growth. The importance of informed consent and the need for a supportive family environment, or one where family support can be provided. The surgery is normally talked about in terms of highly experienced teams in centres with multidisciplinary weight management teams where there is support from adolescent-friendly units. And there is a need for long-term multidisciplinary follow-up. Many of the consensus guidelines also talk about the need for involvement in a bariatric surgery registry because it's so important to gain the data about long-term outcomes of young people who have bariatric surgery. An issue I would just comment here, and this picks up on the issues that Tim highlighted before, is a challenge for healthcare systems is how to ensure equitable access to such services for affected adolescents. In my country and in a number of others of which I'm aware, it is much easier to gain it in the private healthcare system than in the publicly funded healthcare system, and yet those who are most affected by obesity may often not have private health insurance, and so there is a real disparity there. Can we go on to the next slide, please? I want to just point out what is a really impressive longitudinal study of young people having bariatric surgery. This is the Teen Labs study undertaken in the US, 5 US centres. They had largely Roux-en-Y gastric bypass or sleeve gastrectomy. What you can see here is the weight change in the top left and dyslipidemia outcomes in the bottom left at 3 years. And you can see that by 1 year, most of the percentage weight change had occurred, as had the improvement in dyslipidemia. And I do also want to highlight that at 5 years in the same group, about 95% of those who had type 2 diabetes at baseline, it wasn't a large number, but there were certainly a few score of those, 95% had diabetes still in remission. So it can have an impressive outcome. But nevertheless, there are some potential side effects that need to be taken into account, including the need for revisional surgery, the need for nutritional supplementation lifelong, which is more challenging in adolescents, and potentially some risk of psychological harm long term. Next slide, please. So I just want to summarise that we have emerging evidence that pharmacotherapy, intensive dietary interventions, and bariatric surgery are effective adjunctive therapies in those with moderate to severe obesity. We do need further clinical trials in adolescents, picking up the issues that Tim highlighted about socioeconomic response as well. What is the role of these therapies in younger children? They generally tend not to be used as such. If we are going to be using them, then I believe that such children should be part of clinical trials and registries. And an important issue is how do we ensure equitable access to these therapies and also the family-based lifestyle therapies we've already heard about by affected young people. Thank you.
Thank you very much, Louise. That was extremely interesting. Now we're going to open up and ask all of the participants who've presented to be available to answer questions. We have a number of questions both in the chat box and in the Q&A. The first one, which came up during the first presentation by Margot, but could be answered by anyone, is which follow-up techniques do you suggest to use with pediatric patients? So I don't know, Louise, if you want to start with that. And then
Yeah, I think we need to use a whole variety of strategies to support families. So if I can, I'm not sure that we have any systematic reviews on this. I'll tell you from our own clinical practice, and we've been doing this for a couple of decades now. So I think you have to adapt to the community and the types of families that you work with. So we certainly use things such as phone coaching, SMS support, trying to get back for group sessions or individual sessions as needed. This is a chronic, lifelong disorder. It's not something that we should normally treat for just a few weeks or months and then say goodbye. However, I do think it's important that forms of treatment are supported across a range of different healthcare professionals. So, for example, if you have a family doctor, a primary care physician, or a community nurse, they may be the touch point most of the time, but they may be linked into a, say, secondary or tertiary care service as well. So communication across different levels of treatment are important, and a whole range of strategies to stay connected to the young person or the parent, depending on the age of the patient, long term. I think this is where the role of nurses can be particularly important, because I think they can support families long term in a lot of ways, and they are the biggest part of the healthcare workforce in all countries. But we've got to be as creative as possible. I know that people also have things such as websites, email support, whatever's going to work with your young people and your families. I think you have to be creative.
Yeah, I would like to add on that. I absolutely agree. And we have also found a follow-up essential to ensure effectiveness of treatment. We have recently published a study in pediatrics showing that was the key feature to have a extended effectiveness for children with at preschool age. And we use phone calls, but again, you can be as creative as possible there, but to provide a follow-up, it's absolutely essential.
Now, one question's come in around, well, sort of a two-part question around bariatric surgery. One is in places where these are sort of equity issues, in places where that's just simply not an option. How would you reframe a treatment approach? And then the second is, if there's bariatric surgery, but the child or adolescent returns to, the obesogenic environment that has contributed to the obesity in the first place, what are some measures you would recommend, or what do you think are the critical issues in terms of ensuring that there's not weight regain, or that further need for serious treatment in that case?
I might start. I might just, so the first issue is about what happens if bariatric surgery is not available. Could I just say that's essentially the situation where I work in the part of Australia that I live in, Sydney, the largest city. It's basically not available for most adolescents. So I think this is why we need to really support that family-based lifestyle intervention, drug therapy where it's available, intensive dietary interventions and other forms of support are going to be very important. I also think it's very important that we as clinicians, healthcare people, advocate for what is an effective form of therapy. And the fact that it's not being provided is, I think, potentially a sign that, one, we don't recognise that obesity is a disease, and two, that there's a lot of institutional stigma in many of our organisations that respond poorly to what I think is good evidence. But nevertheless, I think you can have some reasonable outcomes with more intensive support of families, and but we need a whole array of options available, and not being able to give bariatric surgery for those who have severe obesity, I think, is potentially a failure of a healthcare system. And I know in saying that I'm talking about my own healthcare system as well as others. So I just want to encourage you, though, to persist, because there are other forms of therapy that can certainly support people. There's the second issue about families, young people, children going back to an obesogenic environment. I have heard it described treating obesity as and then letting families go back as like treating cholera and then putting someone back in the sewer. I hope that's not too dramatic and an example for some of you. So I think this is why we, World Obesity, for example, has this really strong approach to supporting prevention of obesity in its broadest view, as well as the importance of treating people affected by obesity. So I think there are several things there. All the work on bariatric surgery, all the consensus guidelines highlight the importance of regular follow-up of the young person who's participated in treatment, and for long-term, and they're largely talking lifelong. And I think you're going to need to have initially adolescent-friendly services that are there. Adolescent-friendly services, I actually think this is the case for adolescents as well as young adults, that you need services that are quite flexible, oriented towards young people and their families as appropriate, can supply the sort of support long-term that's needed. For example, the phone coaching, the SMS support, as well as regular touch-base sessions back in the clinic. These are all important, but we also need to have a view that we're going to need to support the broader, to more broadly support families and young people in dealing with the obesogenic environment, which is more challenging. I don't have an easy answer to that. Tim may want to comment on obesogenic environments as well.
Tim?
Okay, well, only to say that looking back at the slide that Paulina showed of the differential effectiveness of interventions according to age group, and it's fascinating to see that really, to be fair, they didn't work except possibly for the under fives, and under fives are probably have their environment most tightly controlled and are least exposed to these sort of obesogens of the street or the school or whatever. So you could argue from that actually we don't know the effectiveness of interventions because they're so badly compromised by the environments to which children return and or even in the middle of their intervention. So treatment, we don't know if treatment works because treatment is undermined so substantially by what the children are experiencing for the rest of the day. And I think the example that under fives do appear to show good response to treatment implies that we know what we should be doing, we just find it almost impossible to do it in the modern culture that we have.
Tim, I would agree with you, and I'd just comment upon the challenges, particularly for more socially disadvantaged people, that this may also be a double whammy from that viewpoint for them.
Yeah, agree.
Yeah, and I would like to add another comment about the social disadvantage, and I may be a little more radical when I say that, but I really think that we researchers measure social disparities and report that, and I think that the journal should not accept studies without such measurements, because I mean in the beginning of the field we accepted studies with very short-term follow-up of 3 months, that studies were publishable, and now we became wiser. We understand that we need to follow them longer. So for example, there is this cutoff of 6 months. I think that the same with the social disparities. We need to measure and we need to report, and we need to be tough on that. We need to understand what works and for whom.
Great, thank you very much. These are great points. So there are disparities issues that must be integrated into this. It also just might be worth observing that the places where it's easier to see results are obviously places that are not as large as a country, but cities where there starts to be, you can start to recognize evidence, because it's easier to have multi-sectoral approaches in a city than in an entire country. Similarly, though, it would be wonderful to hear from some of our people on this call who are actually from small island developing states, places where there's a tremendous problem with childhood obesity, but also potentially the kind of the geographic containment that would allow multi-sectoral problems, and that we have multi-sectoral solutions. And we know, for example, in Jamaica and the Caribbean, there's some very interesting integrated approaches that have been employed. So if any of our colleagues from a small island developing state wanted to say anything on the chat box, that would be great. Otherwise, we'll just continue to share case studies. The couple of other questions were, So with obesity being recognized as chronic diseases in some of your countries, which is absolutely correct, does this mean that treatment will be publicly funded and insurance funded? Any comments on that in places where obesity is, from countries where obesity is at least recognized by professional societies, if not fully as a chronic disease or a disease? Any responses to that?
Yeah, well, I can comment. I can talk about Sweden, and well, it is recognized and is publicly funded. However, the availability varies by region. So it's not, if we compare north and the south of Sweden, the variability, there is a variability, the access to treatment, which is, and we don't have any national guidelines as well. And we also provide bariatric surgeries as a part of ongoing research projects. So in terms of availability of different treatment forms, I think we do quite a lot in Sweden. However, we see problem in the healthcare systems, between the linkage between primary care, secondary care, and tertiary care. So while we do have generally good access, we do have a problem in the healthcare system. So it's not ideal, and there is much more, room for improvement.
Okay. One question came up, would we go so far as saying obesity is a classifiable disability? I think in some countries, does anyone have a response to that?
I might just comment that I suspect it depends on the severity of obesity. I don't think it's one issue. I think people, mild obesity, I think very few people would comment that they felt that they were that they had a significant disability. But there are certainly people with moderate to severe obesity in this age group who have many health consequences of their disease, and who have many functional limitations. And I think in that sense we could recognise it as having having a disability. I think there is a spectrum of the disorder, and at one end I think it can be a significant disability for people.
Okay. A question came up about children's tastes and consumption, and I'd welcome anybody of the panelists to respond to this one. It's a slightly long question. Children have little ability to differentiate between consumption for consumption's experience and for hunger. So there's an attraction to Ajinomoto, I don't know what that is, sorry, saccharin, thickeners, coloring agents, and other products of food design. It's accepted at policy level that such addiction should be looked into. Can World Obesity help with identifying research teams who could help in this area? But any comments on that? And we can certainly, we're happy to follow up with you directly, but any comments on that particular question about the way children's being drawn to consumption for consumption's sake? Anyway.
Yeah, it's interesting, isn't it? Because you have theories about addiction or addictive-like substances. I think Ajinomoto is a form of artificial sweetener, I think it's being referred to there. So encouraging sweet palates and sweet tastes, even if you're not getting the calories. The whole issue of addiction, we don't have a policy statement on sort of food addiction as a World Obesity Federation, but I think it is a fascinating area about ultra-processed foods and how they combine fats and sugars and make foods that are perhaps high calorific value into something very tasty, to which children might well be attracted, but don't provide the underlying nutrients that a diet needs. So that's a whole area of interest that goes well beyond the issue of just obesity, because it affects a whole range of chronic diseases, including dental health and all the range of heart disease and cancers and so on. So it is a big and very interesting area, and we'd love to develop that, but we would need some good support for that.
Okay, so we're happy to follow up directly with that person as well, and it's been noted that this is MSG is what we're describing. We are approaching the end of our time together, and I want to again thank the panelists for excellent presentations, and also the many people on the call. We have people from all over the world, and we were really pleased. We were always thankful for the support of the European Union, and also very happy that through our networks, we can help disseminate some of the excellent research that's taking place, so that it goes throughout the EU, but also more broadly around the world. So as a sort of final couple of points, I want to again say that the slides and the recording will be available. I understand some of our colleagues in the Gulf region had some issues; they were not able to hear us, but they were able to read the slides, and so we're happy to just make sure that everybody is able to access the slides and the recording of today's session, because I think our experts provided very, very interesting and important updates and perspectives on the management and treatment of childhood obesity. So, Margot, do you have any other last comments? Otherwise, your email is shown as the if people have questions, please contact Margot at the website, at the address that's given on this slide, with any comments or further questions. And please do complete the follow-up survey for our colleagues. Did any other comments or questions from any of the other panelists, participants? Okay. I want to just thank everybody for an excellent presentation, and we look forward to continuing this very, very important dialogue together in the coming months. Thank you.